Everyone, just giving a second to allow everyone to connect to audio, give a second for some of your colleagues to join us. While we're waiting, I have just a few housekeeping items to take care of, and then we can get started today. My name is Joni Napier, and I'm the Program Administrator with Mental Health America of Kentucky, and I would just love to thank all of you for being here with us today. The session is part of a statewide learning series designed to increase workforce capacity to address early serious mental illness and first episode psychosis. This virtual series is made possible by BSCA funds through the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities. Today's session will be held from 2 to 3 p.m. Eastern Time, and your attendance time will be tracked. Please make sure that your full name is reflected in Zoom, and if it's not, you can click the 3 dots next to your name and click rename to change that. CEUs are not being directly offered by us, but our team is happy to assist you as needed to self-submit for those. And please note that certificates of attendance are only available to those who attend for 50 minutes of each instructional hour, and will also allow for 5 minutes of wiggle room because we know that life happens. As you may know, this meeting is being recorded, and that recording will be shared via our YouTube channel. Please make sure that your microphones are muted, and please put any questions that you may have in the chat box, and we will get those answered. Today's webinar is titled Stigma and Words Matter in Psychosis and is led by Dr. Kristina Medero. Dr. Medero is the postdoctoral associate in the University of Minnesota School of Public Health's Division of Health Policy and Management and the Hubbard School of Journalism and Mass Communication. She is a researcher who focuses on how health disparities often stem from our stigmatized identities and how narratives influence how stigmatized groups may be perceived by the broader public. Her research aims to understand and support social groups that experience stigma. And with that, I will turn it over to her.
Thank you, Joni. Hello, everyone. As Joni said, my name is Dr. Kristina Medero, and I am going to share my slides here. Okay, can I just get a thumbs up or a virtual thumbs up that everyone can see? Thank you, Joni. Yes, so very long title. So I have a dual appointment doing research for the School of Public Health as well as the School of Journalism at the University of Minnesota. And all that really means is I look at how health policy is presented in the media and look at ways to really push for certain types of public health policy that might help certain groups of people, particularly social groups that are stigmatized. But before I really get into the conversation today, I'm not sure where everyone is geographically. I work for the University of Minnesota, but I'm currently living in Omaha, Nebraska. So I would like to take a moment for everyone to just find where they are in the US and recognize the native land that they are on. Thank you. I would also like to recognize the funding from the Collaborative on Media and Messaging for Health and Social Policy, which is funded by a grant from the Robert Wood Johnson Foundation. I will be providing a QR code if you are interested in the work that I'm currently doing with the Collaborative at the end of my slides. Now I would like to start with a little activity. And you can go ahead and put these words in the chat. If you could just think of words that come to mind when you think about pencils, just pencils generally, any words that come to mind. All right, these are great. I've done this exercise a few times, and you all have put similar words that I often get. I used to do this with the thought bubble forming while people put in the words, but I learned that could be distracting for people who have eye sensitivity. So I just use this word cloud. But you could see some of the same words came up. We have wood, writing utensil, yellow, sometimes number two comes up. We talked about how it's used as a writing tool, how it can be sharp, and someone also recognized dull, so put it on a spectrum, which is great. Um, and so we make these useful connections because it's easy for us to process information and it allows us to create a common language. So if I said, oh, can you hand me a pencil or I need a pencil, you aren't going to necessarily ask me, what length do I need? Do I need it to be sharpened? You will kind of go along with the stereotypical ideas of what a pencil might be to help in my request. And while this might be helpful, we can see that there are different types of pencils. So some people say that colored pencils are yellow, or someone said erase. This doesn't have an eraser on it, and it's the color green, but definitely still a pencil. Here we have a little short pencil. Some people say that they tend to be long. When it comes to the number two, when I was researching this activity, I found that there are all different kinds of lead, and those number two scantrons, if you remember taking them in school, you have to make sure you're using a number two pencil. And again, someone said sharp or dull. You can see the differences in types of pencil based on their sharpness. And I believe someone said simple, but mechanical pencils are a little complicated and different. And even different still are colored pencils. So as we look at the diversity of something as simple as a pencil, we can see how it might become problematic when we make these shortcuts and simplifications and overarching generalizations when applying it to people. And so what I want to talk about today, we'll go and define some core concepts related to stigma. And we'll talk about how stigma and health disparities are related. We'll also touch on stigma and the media, and then we'll do some review and reflection for this half. And then the second half will build on this initial hour. But first, it's very important to create a common language when we are talking about stigma. So first, one of the concepts that's related to stigma is this idea of a stereotype. It's a generalization about a group of people in which identical characteristics are assigned to all members of the group. So very similar to this exercise that we just did, where these ideas of being a tool or being used for communication or being yellow or sharp, these generalizations are applied to the whole diverse group of a certain topic. And so when applying that to people, that can become problematic. Now, prejudice was originally defined as just a prejudgment in the School of Psychology, but as we've come to study it, it's come to be more specifically about objectionable qualities assigned to a group of people. And so you can see in this image here, we have a woman looking at two individuals. She has these objectionable ideas, so signified by that red circle, and then positive attributes assigned to another group, signified by that green circle. And finally, we have discrimination. Discrimination, these are behaviors and or structures that directly and negatively impact individuals based on their social groups. Now, many people, when they think of discrimination, often think of the face-to-face interpersonal behavioral discrimination, someone acting negatively toward another individual based on the group that they belong to. I very much want to emphasize that discrimination happens on structural levels as well. So when we think about healthcare systems, how is the way the healthcare system running, barring people from accessing the healthcare that they need? And all of these concepts kind of converge to these interrelated components and systems of power that are stigma. And so stigma it very much exists in systems of power like the healthcare system. And many scholars suggest that it's meant to keep people in. So it creates these negative attitudes and behaviors, and it normalizes those negative attitudes and behaviors towards social groups of people. And when those negative behaviors and attitudes are normalized, it keeps the in group or the high status group in, and therefore trying to associate or be more positive toward those groups of people may come with associated stigma, that you would carry the stigma for going outside the norm. It's also meant to keep people away, and this is very much in reference to the stigmatized groups of people, keeping them out of certain areas, as well as keeping them down. So when it comes to social mobility, not allowing them to ascend to certain levels. And so stigma is very much interrelated with health disparities being defined as avoidable health differences in treatment, access to treatment, mortality, and disease based on group identities, particularly groups that are historically disadvantaged. And so again, within the healthcare system, these disparities might look like differences in access to health services. It may look like efficacy to achieve wellness. Some individuals may not feel capable of achieving a certain level of wellness. It may also have a historical component. So here's an image of a Latina woman getting the COVID-19 vaccine and how potential mistrust in the healthcare system from historical events, for example, like this image, might deter certain social groups from seeking out health treatments. And so many of you may recognize this image. This is from the Tuskegee syphilis experiments, and how that impacted ultimately the Black and African American community being tested on and not being given treatment when treatment was available. The ethical issues with that study and years of research and how that generated mistrust amongst social groups. And so these are kind of the three main areas of my research, looking at stigma, health disparities, and media and narratives. And you can look at the overlapping areas of each of these main circles. So for example, if you're looking at the overlap of stigma and health disparities, you might ask yourself questions like, in what ways does stigma perpetuate health disparities? And there is no dearth of knowledge here. We can look at different stigmatized groups and how they are related to health disparities. For example, among sexual minorities, we see that 29% of transgender patients reported that their doctor refused to see them because of their gender identity. And we can speculate how that might be related to health disparities. For example, LGBT women reporting higher substance use and diagnosis of cancer, diabetes, heart disease, and hypertension. We see a similar story when we look at racial and ethnic minorities. Again, racial and ethnic groups feeling that they are discriminated against and how that leads to differences in care, such as preventative care and pain management treatment, as well as rates of morbidity and mortality. And of course, we can also see this among people with mental illness or mental health conditions who report feeling discrimination from providers, who fear going to seek treatment, and experience difficulties in securing housing and jobs. And so once we are able to answer these questions, how stigma interrelates with health disparities, we can look at these other overlaps. Which is a lot of the research that I do. How are stigmatized groups and health disparities portrayed in the media? And so to look at that, I often draw from the stigma communication model by Smith. And she notes that there are certain marks, labels, and peril and responsibility that come with how we communicate about stigma. Because stigma is related to social groups and how we perceive social groups, it's inherently this communicative process. The way we talk about it is going to impact our attitudes and behaviors toward social groups. And so I'll go through what exactly marks, labels, and peril and responsibility are within communication. So for example, we can look at leprosy as a disease where it causes severe scarring, and there are very much physical marks associated with individuals who have leprosy. Now, this can come from the health condition itself. And, individuals within society can mark or identify those marks as something negative and thus something that becomes stigmatizing. But of course, society can put marks on social groups. So one of the most common examples is the yellow star used during Nazi Germany to identify Jewish people. That mark was used as a form of discrimination and stigmatization for that group of people, ultimately signifying that it is okay to keep people down and keep people away from the high status social groups. We can also look at labels. Now, labels are terms that are used to identify the stigmatized group and often have negative connotations. This is a list from Rose et al. 2007, where they use the most commonly or frequently used words to identify individuals with mental health conditions. Now, some of them are just the diagnosis, such as schizophrenia, but you can see some of these negative connotations here, such as nuts, disturbed, or psycho, how those terms can be used to keep people down in a stigmatizing way. Now, again, these terms are used socially, but sometimes these labels come from the medical field itself. So I'm going to give you all a chance you can type it in the chat or you can unmute. Can anyone tell me what GRID stands for? Exactly. Thank you. Yeah, gay-related immune deficiency. So, uh, AIDS was identified first rather than the HIV virus. And the medical industry, it was first used in 1981, labeled it gay-related immune deficiency, suggesting that a certain social group of people were being targeted by a disease. But as we know, diseases do not discriminate. And so placing that label on a certain group of people created its own stigma within itself. I next want to talk about peril and responsibility. So peril is related to how dangerous or serious being part of a stigmatized group can be. It's very much used as a tool of not wanting to belong to that social group, as well as not wanting to be associated with that social group. Very much used as a tool to instill fear in the general public or individuals who might belong to high status social groups. And finally, responsibility. Responsibility is the extent group members are at fault for their predicament. So a very common example might be cancer-related illnesses, where breast cancer has very much been destigmatized over the years through support and campaigns, as well as health changes and policies meant to support those individuals. In contrast, lung cancer is very much still stigmatized or has higher stigmatizing attitudes because it's associated with smoking. And therefore, because individuals have made the choice to smoke, they've somehow brought on that illness to themselves. They are somehow responsible for that predicament. Another stigmatized mental health condition is that of substance abuse and addiction. Very much the individual is held responsible for their condition and thus stigmatizing that individual as if it is okay for the negative health outcomes they may receive. So now that we have a stronger understanding of stigma and how it's related to health disparities, we could kind of talk about how mental health is portrayed in the media. And there are two kinds of inaccurate portrayals. There is underrepresentation, and this is from USC Annenberg. And their work on mental health and representation. And you can see since 2016, there's been a slight increase in representation of characters who experience a mental health condition, from 1.7% of characters in the top 100 films to 2.1%. And so that's not a lot of representation. So from over 3,000 characters, only 2% of those characters experience a mental health condition. There's also misrepresentation, and these two concepts are interrelated. I will talk about how they are related in a second, but let's look at them individually first. Misrepresentation, again from USC Annenberg, they noted that 72% of film characters with a mental health condition in 2022 were perpetrators of violence. And so when you have so little representation, yet the majority of those individuals are perpetrating these negative behaviors, the association of those social groups will be strengthened within an individual who is exposed to that media content. Something similar will be characters with mental health conditions who perish in the films. And you can see here is a list of how they died in those films. Some through suicide, overdose, alcoholism. And you, again, looking at that model of stigma communication, how the peril and this idea of danger overlaps with these inaccurate portrayals of how social groups are represented in the media. So again, I want to take a moment for you all to participate as well in the chat. We've talked about entertainment media quite a bit so far. Where else may you find these inaccurate portrayals? Absolutely, in the news, social media, yes. Yeah, that's perfect. That's exactly what I have here. We have commercials. Oh, yes, there's a lot of research also on PSAs that are meant to increase individuals' help-seeking behavior for mental health conditions. But there's this great research by Jason Siegel. I don't have it in this presentation, but great research there where he notes that the PSAs are often more harmful than good. But we can talk about that when we get to the questions. Yes, news portrayals, absolutely. The way the news portrays mental health is very important to guiding how we think about mental health or individuals with mental health conditions as a social group. And that's much of the research that I do. So what USC Annenberg and what I'm about to talk through now is called a content analysis, where we review media and try to identify how individuals are represented in the media. So this is a project I'm working on right now, news media representation of Black youth and mental health in Minneapolis. And so in order to conduct this content analysis, we collected 972 news programs. So every news program that ran from July 1st to December 31st of 2023 from the 4 major news stations in Minneapolis. We use keywords to identify potentially related stories, so synonyms related to Black, African American, youth, juvenile, young, child. We also use mental health, mental illness, as well as specific mental health conditions such as depression, schizophrenia. Um, and then we also included bully and school shooting because these are events within youth's lives that may lead to mental health issues. And so when we conducted this study, like I said, we had 972 news programs from those 4 major news stations. Using the keywords, we identified potential 985 clips. And then we removed all the duplicates. So there were 276 potential programs that had more than one clip within there. And then we read the transcripts from the programs and identified 82 relevant clips for analysis. And during analysis, we removed 8 more because they were outside of Minnesota. We really wanted to focus within Minnesota and more closely the Minneapolis area. And then we removed 14 more because they were about mental health, but they weren't necessarily in reference to the youth specifically, nor the Black community. And so when we finally had our 60 clips that we were going to watch, we watched them and identified locations that were mentioned, specific mental health conditions. We looked at engagement if the news program asked them to contact the news station for information. We looked at what groups were represented, the story, the general stories that were being told, who had an opportunity to speak during those news stories, as well as the representation of those voices. So not just who was speaking, but what demographic communities did they also represent. We looked at the general tone of the stories, and finally, we looked at what characters were being represented, such as protagonists and antagonists. So a few characteristics about those 60 clips is that they were about 2 minutes in length. They were fairly distributed from those 4 major news stations, with WCCO reporting the least on mental health. We also see fairly equal distribution throughout those last 6 months, with the least being December. We can speculate that maybe it's because it's the holiday season, and so they didn't want to do stories on mental health. We also see that much of the information was either focused on youth or the Black community with some overlap. And then we see the tone. There's some positive tone, neutral tone, happy endings. And so a happy ending is a story that starts off negative, but by the end of the story, they provided a solution or something that was positive to look forward to. And kind of just a characteristic of the news, most of the stories were negative. So they started negative and didn't really provide a solution to it. They were just reporting on this negative thing that happened in the community. So again, this project was about Black youth and mental health in the news media. And so when we try to find the overlap of stories specifically about Black youth, there were only 6 clips about Black youth specifically. And the location mentioned were Brooklyn Park, Forest Lake Park, and North Minneapolis, all predominantly Black communities. The mental health conditions that were mentioned were trauma, and then mental incompetence was noted as a mental health issue. And then the types of engagement, they often ask the audience to either contact the police with information or to donate money to a specific group. The images that we saw a lot of criminal activity or schools being represented. The groups that were discussed within the stories often included parents and corrections officers. And then when individuals were giving voice or speaking within the stories, we saw that there were Black youth, parents, and community members. What was interesting is that when correction officers were talked about, there was no one specific correction officer speaking. They were kind of talked about as this general entity in the area. And then unfortunately, all 6 stories had to do with crime. So 2 were related to crime caused by a mental health condition, or the story suggested that it was caused by the mental health condition. And there were 4 crimes that the story suggested would result in mental health issues, such as trauma. And then, as you can guess, the tone was predominantly negative, and the characters represented were these victimized protagonists and then the criminal antagonists. So again, we can see how this is related to what we've discussed so far about these inaccurate portrayals of Black youth and mental health. There is underrepresentation, where there's only 6 stories about them over 6 months, and misrepresentation, that when they were being spoken about, or when the story was specifically about Black youth, it was related to crime. And so as a quick review, when we have these limited representations, the associations we tend to naturally make, again, by no fault or of our own, this is just how our brain works. It's important to try and recognize how the media may be reinforcing these inaccurate portrayals or these stigmatizing ideas so that we can unlearn them. And so ultimately, in some interpretations from this study that we've been doing is that, again, there's low representation of Black youth and mental health. And when the stories about Black youth and mental health are told, they are predominantly negative and about crime. So as a quick review, we've discussed how stigma is a communicative process, that we have to talk about it socially in order to reinforce these ideas. It is meant to have a certain high status group in a power system maintain that power, and to normalize the negative attitudes and behaviors toward the low status group. The media influences can inaccurately portray those social groups, and there are inaccurate portrayals can be stigmatizing in the way they represent those social groups. And so I would love to do a reflection and have, again, everyone just respond in the chat. And you can respond to both questions or one if you feel more comfortable. Or if you'd like to unmute, I'd love to talk to you all as well. What portrayals of mental health have you been exposed to in the media? If you could take a moment to reflect on that. And then how have those portrayals impacted your attitudes and behaviors regarding mental health? All right, so I'm seeing some responses. McKiley says when mental health is portrayed in media, it comes off as a bad thing. Like those with mental health problems only do terrible things. They seem to not be able to live normal lives. Absolutely. There's a lack of they tend to show the worst case scenarios. Absolutely. Movies like Me, Myself, and Irene gave a silly bad portrayal of mental illness. It was showcasing yes. And then Six Brothers was mostly violent and true stories. Tia, thank you. Kelly says criminal behavior in fictional shows hasn't impacted my impression, but I make a note to point it out in psychology courses I teach. Thank you, Kelly. And then Christopher, during the protests of 2020, the news media kind of always talked negative of that everywhere I went. It got so tiring. I actually shut off. My mental health got so much worse. Hmm. People with mental illness are characterized as erratic, dangerous, unpredictable, and not everyone behaves this way. It makes the general public afraid of them and believe they need to be institutionalized, kept away from society. Absolutely. Thank you, Lakeisha. These are great. Based on these responses, I feel like you all have heard the conversation and you're able to apply these concepts very quickly and see how they might impact not just yourself, but the general public. And so how we might work against that dominant narrative is what we call it in communication. So for example, with the Black youth and mental health, I just ran a few focus groups with Black youth, asking them how the news can change their storytelling to be more accurate. And we got some really great feedback on changing the story, changing the tone. And what was most interesting was allowing Black youth to have voice in these stories that are being portrayed in the news media. Um, One of our participants suggested that, well, they film debates all the time. Why can't they live stream Black youth and their experiences with mental health to create this destigmatizing story? And it's very much true that community storytelling can start to unpack the way we have made these associations, these inaccurate associations that are indeed stigmatizing. Thank you all for your reflection. We have about 20 minutes left in this first half. And so I want to open this up to questions you might have about my work, about the concepts I have discussed so far. As I promised, there's also a QR code here for you to use if you're interested in the work we are doing with health and social policy, as well as how we communicate those issues. Okay, question from Lakeisha. How do you think we can address stigma about seeking help within communities that do not discuss mental health openly? Oh, communities that don't talk about mental health issues. Um, that is a great question and a question that was brought up among the focus groups. So, one of the main issues that the youth talked about was a generational gap where their parents and grandparents uh, don't talk about mental health within the Black community, uh, or they outright don't believe that mental health issues exist. That it's almost a cultural taboo to talk about. And so we talked to them about what could change, and one of them noted that maybe changing the news would impact that group. So they noted that the news is for old people. That's what they said. That's their quote, not mine. Um, and so they said we could use the news to convince them that what we are talking about in terms of mental health is really happening. And so that was one uh, a solution that was posed by the Black Youth Focus Group. But when it comes to talking about mental health, there are also culturally centered ways to talk about it. And so, again, within the Black community, there's been interviews and research done where people talk about it, but they don't talk about mental health in the same way we might talk about it within the health community. And so working directly with communities to see how they define their health issues could be another way to discuss mental health, even if they are not calling it mental health or mental health issues. Making sure that we're using their vocabulary as at least as a starting off point to build that trust and rapport before trying to, change the way that, they talk about health issues. Does that answer your question, Lakeisha?
Yes, it does. Thank you so much.
No problem.
I appreciate it. Hi, Kristina. This is Allison Paul Perry. I am the program administrator for First Episode Psychosis here in Kentucky, and we're so glad to have you today. I will admit that I had some technical difficulties, and I missed the first 15 or so minutes of today's presentation, and so I apologize if my question was already addressed. But I was curious as to, it kind of piggybacks off of what Lakeisha had asked. When we have populations or, communities that aren't very open to talk about mental health, what are some of the ways that we can gather that information? I mean, we have like our historical, people send out surveys and, sometimes you get good responses there and sometimes you don't. And so how do we really gather this information from communities that maybe we're not already, well established?
I think the first step is creating a connection with that community. So again, trying to find community leaders and doing a lot of community-based research with them. So not just saying mental health is an issue in your community, let's talk about it. Starting a step or two before that and say, what are the health issues in your community? Eventually leading into discussing mental health and allowing them to guide the story and tell the story. One of the first things you can do is find, again, community leaders. How are they, solving their problems? How are they getting resources? How are they addressing health issues within the community? I think that's the first place to start in building up that rapport, building up that trust, and then asking them how they talk about mental health issues. And so sometimes this comes from focus groups. It's a really good way to start to understand the way they define mental health. And oftentimes you can put together, the best questions for a focus group, but you might have to reword it. One example with the Black youth, I was asking a question about how was it worded? It was, if you were the editor of a news organization, what stories about mental health would you talk about? And at that point in the focus group, they were so anti-news, saying that it's inaccurate, it's negative, the tone is awful, that they couldn't even associate themselves as an editor of it. So I had to reword the question as, what could the news stations do to change your opinion of them, to build trust again in accurate storytelling? And that's when we started getting solutions about mental health. And sometimes it really is just having the conversation with the community members. If they don't have established vocabulary of talking about mental health, or mental health issues is a taboo topic, you have to have these interpersonal conversations, host focus groups, provide food, make the space feel welcoming, and allow them to tell their stories.
Thank you for that. I really appreciate you kind of pointing out, making those direct connections, and then, also pointing out that, how, letting them be the leader of the conversation. I love that. Thank you.
No problem. I have a question in the chat from Christopher. How do you think we could change the way of how some media affects mental health as a whole? There are youth in my area who hear and see this stuff, and they all agree that it can get tiring, especially with the stigma going on involving that certain media. Stay tuned for the second half of the presentation, where we talk about changing the narrative of how we can start to exactly what you're asking, Christopher, strategies for changing the way we talk about mental health. As a quick preview, one solution is storytelling and allowing the community to, talk about that issue, as well as providing a spectrum of stories. So we've talked about how the media often portrays the worst case scenario or the most negative portrayals. There's been a lot of recent work that when you present mental health conditions as a spectrum rather than this is schizophrenia, where it's like very extreme, we can start to change the narrative by saying this is schizophrenia and this is schizophrenia and this is schizophrenia, and showing lots of different examples of how people manage it and care for it starts to help people destigmatize the stigma. And ultimately, when it comes to the general public, increasing empathy toward individuals within specific stigmatized social groups. Empathy and trying to create a higher level of who we consider the in-group and out-group is another strategy. But again, I don't want to get too far into my next presentation, but that will be the next segment.
All right, I appreciate it. I thank you for that.
No problem, Christopher. Thank you for your question. And I have another question from Tia. When researching a specific mental health disparity, how would you recommend someone begin finding reputable sources? There is I use a lot of academic journals. Health and Stigma is the journal that you can use. There's also really great health research databases that you can use. What I can do is I can make a list of what I commonly use. I'll send it to Joni, and Joni, you can send out that list to everyone who's attended. Yeah, okay, great. So Tia, I'll send you a list of some health databases that I often use to start researching these disparities. I will say with a caveat that they're mostly helpful looking at it at like a national level or within specific cultural communities. If you are trying to figure out a disparity within a specific geographic community, I would say the best place to start is with the community. Absolutely, Tia. Well, if there are no other questions, I again want to thank everyone for their time and for listening and the wonderful questions that we had, as well as reflecting on the information I was able to go through. Like I said, there is a part 2 to this presentation where we'll discuss some of the solutions to these misrepresentations and how we can start to unlearn the associations that we've made from the media, as well as just, living in society and communicating with our social groups.
Everyone, thank you so much, Dr. Medero, for that. I am going to go ahead and paste in the chat the link where you can register for part 2 if you haven't done that already. It's coming up at 3:15, but tickets are on sale until 3:14, so you still have plenty of time to sign up. And I'm also linking the post survey, and through that you can request a certificate of attendance for today's session. You will also receive this in an email, so if you lose the link to the post survey, don't panic, you'll get it again. I just want to thank everyone again for being here and spending a chunk of your afternoon with us, and thank you so much, Dr. Medero. This was great, and I'm sure a lot of great information that everyone's really taken to heart and will find really useful in their professional lives. So thank you so much, everyone, and we hope to see you again here in a few minutes.